Journal club is a very important and integral part of any PG teaching program. Last week we had a webinar from the research department wherein we had a wonderful discussion regarding converting PG thesis to a publication. There also the importance of journal was highlighted, and how to read the journal and how to get maximum out of journal was highlighted. But often we feel that journals are required for research. We have not understood the importance of journal reading in clinical practice. When it comes to the question of clinical practice, we just are interested blindly following the guidelines. We have become blind guideline followers. So there is a need for organizing a meaningful journal club in our curriculum. And for that, we must get prepared. And we do have a very good SOP on conducting journal club, but somehow that has not been implemented fully in all the departments. So I thought having a discussion on conducting a journal club will be useful. And once everyone is aware of the ground rules of conducting a journal club, it can progress, because we learn with each journal club how to conduct it and how to get maximum out of it is something which we keep on learning. So this it is never-ending process wherein journal clubs are continual learning exercises. So with this background, we move on to the. Am I able to share my screen?
We are not yet able to see it, so it should be coming. Yes, sir. We are able to see your screen now.
Yes. Screen. I'm not able to see the proper screen in my computer. I'll stop sharing once and then come back to sharing again. Are you able to see the PowerPoint?
The PowerPoint is seen, but not in the presentation show mode yet. Yes, sir. We are able to see in the slideshow mode now.
Okay. I'm in the first slide, which is Journal Club what, why, and how. Is that the one which all of you are seeing?
Yes, sir.
Yes, sir.
So it's not moving the slideshow mode here. Am I in the second slide now?
Not yet.
Not
For
yet.
us,
Not
sir.
yet. Not yet. Now I think you're in the Wikipedia. Are you able to see the Wikipedia?
That's
yes.
right.
Now, correct. Now, when we say journal, the Wikipedia says it is sometimes used as a synonym for a magazine. But a journal is much more than a magazine. And when it comes to academic field, it is a serious, peer-reviewed, scholarly publication. It is not a simple magazine. There is a serious thought process in the content. It is peer-reviewed. There are people who have gone through that and vouch for the content of that. And it's very, very scholarly, which means that it is required for research and also the practice of medicine. Why do we need a journal or journal club? Why should we have the habit of reading journals? What happens is these days, there is a tendency to follow the narrative and ignore what is narrated. We don't go through the intricacies of the materials and methods or the analysis of the paper, and we just are trying to follow the narrative given by the lead authors or the editors. Now, that will lead to a situation where we are not able to interpret what is mentioned in that, and we simply follow the narrative. And that's what happens in social media or magazines. There, the narrative is important. But for a serious scholar, for a serious practitioner of medicine or any researcher, we need to be focusing on what is narrated than just follow blindly what is narrative. In higher education, especially medical field, the practitioner or the consultant should have the ability to synthesize his own conclusions from available information. The information can be sketchy or it can be exhaustive. It may be from good source or bad source, but the consultant or the researcher should be able to synthesize his own conclusions without being influenced by the summaries or narrative. That important attribute is required for all the higher education practitioners. We should come out of this culture of blind following or the herd mentality. You would have seen the recent COVID pandemic. Every day you would have seen guidelines after guidelines. Everyone was interested in headline of the guideline, but never went to the depth of the guideline and found out what was in the guideline. And this kind of herd mentality or blind following will not lead us anywhere. We will be creating more confusion and will never be in a position to lead the research nor the clinical practice. And overall, unlike Western countries, the research and journal reading both are neglected in India. If you see the medical educational curriculum in Western countries, even undergraduate students focus on research, and by the time they come to the internship, they're already into journal reading. And when the round starts, it starts from the latest review article that has been published recently, and this is brought by the resident. And the consultant just simply will discuss some of the new aspects of these reviews. So in the Western countries, already this is happening. The research and journal reading is integral part of both undergraduate and postgraduate curriculum. And it's high time that at least we start that or implement it in our postgraduate curriculum. There's so much of hype from the social media that we forget the scientific media. Social media is not peer reviewed. It goes just by narrative, just by headings, and not the content inside. Whereas scientific media, that is the journal or reading of that, should focus on the content and the analysis and interpretation of that. So journal reading is not just reading, it is interpreting. And we have the obligation to train our students. And this important component has often been ignored in postgraduate teaching. We were lucky to have been trained by some of the best teachers in our college who taught us the ABCDs of journal reading. And it is our duty to pass on this important knowledge and practice to our students also. So it is not just desirable, it is obligatory on our part to be aware of the intricacies of conducting a proper journal club. Textbooks are very much required. There's no question about that. Textbooks are the fundamental building blocks of education, especially medical education. But it is being supplemented and complemented by the journals. These are not competitive, these are complementary. Both are required. While textbooks give us the proper foundation, the journals give us the superstructure, and both are required. There is no question of focusing only on journals when we have not even read our regular textbooks. And there is no point in just focusing on the textbooks unless we incorporate journals and journal reading as part of a regular curriculum. PG teaching is a very fascinating aspect. Unlike UG teaching or unlike PUC or high school teaching, PG teaching is very much different and interesting and rewarding also and satisfying also. There are various kinds of teaching programs that are used in the PG teaching. It may be a seminar, bedside teaching, or focus teaching, or problem solving, and journal club. Each one has its own purpose, and each one should be conducted differently to achieve to derive maximum out of that. For example, in seminar, the importance is on imparting a knowledge or information. Whereas in bedside teaching, the importance would be on passing on the important aspect of experience from the professor to the students. So each teaching as method has its own purpose, so we can't get confused between their objectives. The journal club is unique in that it is not just information, it is interpretation. While seminars provide information, journal clubs train a person to be interpretive. So informative and interpretive are two different aspects. That is why a journal club should not end up as a seminar, because the purpose is entirely different. When a PG student reads presents a journal article, the focus should be on the interpretive aspect of that, not just the conclusion or the summary and just getting deviated from the core aspect of journal reading. Often our journal clubs end up as journal seminars. That happens mainly because we have not applied our mind as to the proper functioning of the journal club. The topics are given just 1 or 2 days before to the presenter, and then we don't come prepared. We just come there and sit there, and once the topic starts, we think about the topic and start giving our experience on the topic instead of focusing on the interpretation of the findings or the methodologies. So the focus should be on the findings of the particular topic, and it is very easy to just pass on our experience to the students and then think that that is the purpose of journal club. That is not the purpose of journal club. We have to be focusing on our experience of interpreting the journal, and that is the most fundamental aspect of the journal club. Otherwise, what happens is we just limit ourselves to headline and conclusions. Whenever a journal article is presented, you look at the title and then the headline and the conclusion and the narrative of that, without going to the depth of what is there. Unless we dive deep into the journal article, we won't get the real benefit out of that. And in the bargain, if a proper journal club is conducted regularly, the student will be able to be a self-sufficient consultant in the future. And that is the main aim of medical education, not just imparting the knowledge, not just giving the information. There are so many aspects, so many ways of getting the information with the Google or with Professor Google or with so much of electronic media. Getting information very easy. But what is difficult is to be a self-sufficient consultant who can interpret this information, and we have an obligation to train our students to become self-sufficient consultants. Often, without this kind of training, they become blind guideline followers and they just repeat what has been told to them. Knowledge will flourish only when there is questioning, curiosity, and critical analysis, and which is the main component of journal reading. We can't train a student for every possible we can't give a solution for every possible problem that they are going to face, but we can teach them how to get the solution. So we should be able to teach them method to get the solution instead of giving a ready-made solution for every problem. And that kind of skill will come only from regular journal reading. And this process has to be assisted by the faculty members. That's why in MCA curriculum or any higher education, the journal reading is an integral part of the postgraduate training, and it is structured and organized in the curriculum as a journal club. In the journal club, the focus should be on the analysis of the content of that or the findings of that, and to make it easier, it is always a good idea to have a structured format. It is not necessary, but it is helpful to have a structured format, especially in the initial stages. Otherwise, the students will go in different directions. They will lose the main focus. And to maintain this focus, it is a good idea to have a structured format, which is already available in the departments. The SOPs and the structured formats have already been sent to the departments, and PGs can follow this so that they don't miss out on the components of the analysis. Whereas once they gain enough mastery of the subject, they can present it even without that. But it is a good idea to have a structured format in the initial stages. It is a good idea for the faculty members to read the adjoining editorials or podcast because they add a lot of value or understanding of the paper. If there is a paper on remdesivir in a New England Journal of Medicine, there often will be an editorial along with that, and reading that will give you a lot of insight into the concept, and that can add value to the journal. Almost every major journal has a free podcast. For example, New England Journal of Medicine has a podcast, and along with the editorial and the main article, there would be an interesting podcast as an interview with the author. And if you listen to that article, there will be some more additional points which can be incorporated into the journal club. So adding value to the paper can be in the form of reading accompanying editorials or listening to the podcast wherein authors are interviewed, and most of the podcasts of the major journals are free of cost. for each journal, it's good idea to know what the learning objectives are. And if your learning objectives are well understood and focused during the discussion, the time is not wasted. For example, you may have a very good paper on case control study and you want to highlight and describe the case control studies in that journal session. Keep that as the learning point. Or if you want to show how blinding has affected and that has been the problem in that particular article, keep that focus during the journal club. So understanding and identifying a learning point before allotment goes a long way in making it a meaningful and focused discussion. But the most important point is that we must understand time is required. HODs should understand that the faculty members need to be given a protected time for preparation of journal club. Otherwise, the faculty member will come at 8 o'clock in the morning and all of them, both the faculty member and the students will think about a topic at 8 o'clock in the morning. That won't help at all. The faculty coordinator needs a protected time. The faculty guide needs a protected time for preparation, because the preparation starts with selecting a topic itself for the journal club and then reading it. It takes a long time. It takes at least about 1 hour for reading one small article in detail and make notes and prepare for it. And staff coordinator has to be assigned in every department so that the moderator can change, but staff coordinator should be the same person who will oversee the functioning of the journal club, because otherwise there will be variation from the session to session. The moderator can change, but the staff coordinator can be the person who is given the responsibility of overall conduct of journal club. And the criticism of the article is more important than just the content. Criticism is not in a bad sense, criticism in a positive way. Whenever somebody says something in the article is wrong, or if I say something in the article is wrong, I'm not saying that the article is wrong. I'm just talking about the content of that. So we should not hesitate to criticize the content of that, and we should understand that we are not criticizing the journal nor the author. Anyone who has published a paper has taken so much of effort. We should appreciate that. And our effort, or whenever we criticize, it is not the criticism of the person or the journal. It is only the content or the findings. So we should make clear distinction between criticizing a finding and criticizing everything else. You must give the young minds the chance to dissect the study and present their opinions. Give the article well in advance. The PGs have got very curious mind. If you give proper direction, they will dissect out the study and present their opinions. I have seen many PGs who are able to do a very good job of analyzing the study, provided they have given good guidance how to do it, and with a checklist or the SOPs, and then they are able to do a very good job of analyzing and presenting their findings as a PPT. And you'll be surprised that they can add a lot of knowledge to whatever you know. Be ready to be surprised by the wealth of knowledge these young minds can add. And it's always a pleasure to interact with these young minds, because even with minimum guidance, once or twice you will tell them how to do it, then third or fourth time they will be able to do that, and fifth time they are the masters of that. And they can add a lot of knowledge. And once you come to that stage, you would like to come to a journal club because you will learn a lot of things. And from that point onwards, it's a learning process for everyone. That's why don't hesitate to guide the young minds. When they come to the postgraduate course, they are not generally aware of the dimensions of journal club. You guide them properly, tell them properly 2 or 3 times the initial phases, then they take off. And from then onwards, each journal club will be a very fruitful exercise. Take the help of other departments also. It is not possible for every clinician to be aware of everything else. A journal article involves a coordinated process of clinicians, statisticians, writers, journal editors. So it has come through the coordination and cooperation of so many people. And while you analyze that, you alone may not be able to understand it fully. Don't hesitate to take the help of others. For example, statisticians. These articles are very, very heavy on statistics. But then with the small help from statistician, we can go a long way, and their help can be either be present there or through online, or you can speak to them before the journal club and get necessary information. But remember that interpretation should be from the clinician. Statistician will be able to give you the overall interpretation of the numbers, but what is there behind the numbers is to be interpreted by the clinicians. And you can invite other experts from the different departments also. For example, if you have a paper in the Department of Medicine or Surgery or OBG, you can also invite senior professors from other departments like pharmacology or even microbiology or anatomy, because the basic methodology of analysis is almost the same. The concerned clinical department may be able to add a few clinical points, but then the basic methodology remains the same. So you can invite other experts or other senior professors from other departments, and that will add a lot of value to the overall understanding of the content of the article. And at the end of the discussions, senior professors can add from their experience, from their practical knowledge, they can add knowledge to the overall discussions. So the senior professors should take part in a subdued manner in the initial phase, allow the juniors to come out with their findings, and take the opinion from other guests or invited professors or statisticians. And at the end, the senior professors can add value to the overall discussion by adding the wisdom from their experience. And not only that, we have SOPs for all this. I've told you that there is a SOP on Journal Club also. If you go to the MU portal, you will get that. But unfortunately, these SOPs are not followed fully. And even during the ISO audit process, I think these processes are not given the due importance. The auditors are often, I'm not talking about external, even internal auditors are often worried about small spelling errors in the attendance register, or signing in one area or the signing in other areas, or not adding the subject of the class on that particular day. But they don't see whether SOPs have been followed in the conduct of a journal club at all. If the auditors are regularly checking the documents regarding the SOP of journal club, that will go a long way in proper implementation of the journal club. Like anything else, even journal clubs have got some basics. ABCD of the journal club: A for active participation, B, before the meeting itself there should be preparation, C for critical analysis of the content of the article, and D, this discussion. These are the four main pillars of the journal club. There has to be active participation. Everyone should contribute to the discussion. It should not be a dialogue between the moderator and the presenter. There will be lots of points from each person, and only when there is a 365-degree input from everyone concerned, only then there will be a good discussion. So there should be active participation, which should begin much before the meeting. At least about 7 to 10 days before the meeting, journal club meeting, the article should be sent to everyone, and then people should prepare for it. And on the day of presentation, it is not the journal reading; it should be a focus on critical analysis of that article, and there should be good discussion after that. And the success of journal club depends upon these four components. There should be a good intent, there should be good interest, and it should be implemented and should be evaluated. Intent should come from the head of the department or the senior professors, that the intention of running a fruitful journal club should be there from the higher levels of faculty members in the department. And there should be interest from all concerned. There should be interest from faculty members, interest from the postgraduate students also. And then it should be implemented as per the SOP. And the audit should evaluate whether this implementation has been appropriate or not. And with that, there should be feedback back to the HOD. And then the intent has to be there to modify it and then improve it. So this cycle should go on, and only when all the four components have been implemented will the successful journal club be running. So I told you regarding journals. And what is the journal club then? The journal reading is understood by all of us, critically analyzing each content of that. Then what's the journal club? It is an organized way of reading and analyzing the articles. The objectives could be to know the latest in the field, or where some case-based problems have to be answered, or there is skill to analyze the paper critically is learned. To me, the last one appears to be the most important purpose of Journal Club, that is to impart the skill to analyze a paper critically. That's the most important purpose of Journal Club. And these objectives have to be set by the department. There should be a staff coordinator, and all should have read the article before coming for the discussion. This is the most important point, and HODs and staff coordinators should ensure that the selected papers are sent well in advance so that everyone can prepare and come for the discussions. There can be three components of the journal club. One is for improving analytical skills of the residents. That is where reading an original article is important. Original article or a landmark paper, this can be read for improving the analytical skill of the residents. The second component is a review article for in-depth knowledge of a disease or a concept. And the third small segment could be for recent updates or summaries of recent developments. So the three purposes can be achieved by three different activities. A major part of should be for reading original article, a landmark article for improving the analytical skill of the residents. The second component should be for review article for in-depth knowledge of a disease or a concept. And last segment could be for latest updates in summary form. Not much of discussion, but just to bring out the headlines. There is SOP in the college for running journal club. I'll just point out some of the processes in that. The SOP might have changed now because it's a document which keep updated periodically. Please go through the latest SOPs and implement it in the departments. Journal club should be conducted at least once a month. There should be one faculty member appointed as a coordinator for every journal club or a moderator. And residents should select the papers in consultation with the staff coordinator. And there should be one original article for half an hour, review article for 20 minutes, and a few summaries regarding latest developments, just the summary points over the next 10 minutes. So over 1 hour, three components can be done. And articles should be selected at least 7 to 10 days before the journal club meeting. And the paper for discussion in the original article should be circulated among all the residents as soft copies with a request to read and come prepared with their notes. And all the residents and staff members should have read the paper. And discussion is not on the paper, but on the interpretation and analysis of the paper. There is no point in reading the article again on during journal club. That is, it is expected that everyone has already gone through that. Now start the discussion from the interpretation of the findings. The residents should be told that they should not do cut and paste. They should prepare their own slides regarding the contents and their interpretations. And if there is a if they follow the checklist, it becomes easier for them in the initial stages. Later on, they can present in their own style. And they should focus on the design of the study. Is the study question scientifically interesting or relevant? These are the components of the checklist. Is the study design appropriate for the study question? Have the objectives been clearly stated? Is the sample size adequate? If it is a randomized control trial, is the randomization explained properly? And was the randomization concealed from the patients, clinicians, and researchers? Were the group similar in all the respect except for the study intervention? So these are the things that they need to look into when they look into study design. They should see whether the blinding is appropriate or not, whether the follow-up was complete or not, whether there were dropouts or not, how many dropped out, and if so, why did they drop out? Because they should know that if there is significant dropout, that may change the final outcome. And what were the interventions and what were the co-interventions? There can be other co-interventions also. Sometimes these co-interventions may have a lot of bearing on the overall outcome, so they should look into the co-interventions. And they should also look into the outcomes. This is something very important. The outcomes that is mentioned in the article may not be the appropriate one for a clinical, meaningful clinical outcome. So the resident should be able to, the PG should be able to see the outcome and see whether it is reliable or whether it is meaningful to their practice. And whether it is statistical significance or clinical significance or both. There can be statistically significant results, but clinically they may not be meaningful. So the students should be able to understand the difference between statistical significance and clinical relevance. Often they are only worried about the p-value of less than 0.05, but that is only for statistical significance. And we have to also see the clinical relevance also. And they have to go by the 95% confidence interval to see the overall, which is the measure of overall outcome. And then we must see whether these results are appropriate for our setting. There is no point in having intervention which is not available in India and reading about it in detail and then ultimately saying that we can't do it here. So the results, the methodologies, intervention should be meaningful for our practice. And we should see whether they're relevant or applicable to our practice. So all this has to be brought out in the checklist. And this is one sample checklist. You can modify it or alter it. And in the Department of Medicine, we give this checklist to the residents and we ask them to fill up these columns, and so that they read and enter their thought process, they enter their opinions into the columns and present it as a PPT. And if everyone has read the article, the journal club can begin with the slide itself directly, because there's no wastage of time reading what is already read by everyone. And the journal club starts with the checklist which is entered by the resident before coming to the journal club. And it contains all the relevant points, mainly for the randomized clinical trials, whether the purpose was stated, background was described, whether study design was appropriate, what was the nature of the study design, and what was the inclusion exclusion criteria. All these have to be entered by the resident in their own words. And what is intervention? They should not be allowed to do cut and paste. They should fill up the description of the interventions, and they should also write what was the outcome. And when they write the outcome, then they understand whether it's meaningful or not, and whether it's applicable to our setting or not. And then the results were reported, whether statistical significance was mentioned, whether clinical relevance was mentioned, and whether the conclusions are appropriate. Often the conclusion in the article may not be appropriate, may not be related to the results. So that has been brought out by the resident, that the conclusions are not what is written in the results. So generally, any good article will have a conclusion based on the results itself. And then we can ask them to fill up their opinion regarding the overall paper, whether they agree with the interpretations, what are the major strengths and weaknesses of the study, what further studies can be done, and did they notice anything interesting in the study that needs to be reported. Because once they do all this, that is where we get new ideas for new research. And this is where the senior professors can add value from their experience. So once this slide comes, then that's the main stage where the senior professors can add value by their experience. And once the residents are able to identify the interesting points, or they are able to identify future prospects or new topics for research, then that becomes a thesis topic for the next PG candidate. So that's how a good, meaningful journal club can translate into future research activity of the department. So in summary, the reading of the journal should be regular. We should select the journals selectively, but read effectively. We should not read everything that comes out of the journal. We should be able to select the article properly. So that's why selection is important. But then we must read effectively. Whatever has been selected should be read effectively. And we should be able to come to our independent critical evaluation and decision, and we should be able to apply it in context. So these are the basic principles of journal club, wherein regularity, selective reading, effective reading, and the ability to come to independent critical evaluation judgment and bringing whole thing into the proper context is trained. Now, this is overall SOP for the journal club, wherein I've highlighted the importance of a journal club, the need for journal club, and how to organize a journal club. We have the SOPs already, but it requires the commitment from the higher ups in the departments to initiate the process, implement the SOP, evaluate it periodically, and implement it again. And one single point that needs to be altered is giving the paper well in advance, and everyone should prepare and come there and present it. That will change. Once that is implemented, the entire process of journal club will be having facelift, and it will be a joyous process to come to the journal club. And I have to explain this process further. I had given you two papers which came out recently. Both were on the current topics of COVID-19. And one paper was on hydroxychloroquine, another one was from remdesivir, both competing lobbies. And these papers were given with the intention of explaining how to analyze these papers. The purpose here is not to say whether HCQ is better or whether remdesivir is better, whether Indian paper is better or whether foreign paper is better. That's not the purpose. We should not get into these kind of narratives, and we should focus on the content of these papers. I gave this paper to one of our PG students, and within 24 hours, he prepared analysis of his analysis and sent me this PPT. And I'm going to share this PPT, which was prepared by one of the medicine PGs. And this was the paper which was given to you, to all of you, which was published in Indian Journal of Medical Research, Healthcare Workers and SARS-CoV-2 Infection in India, the role of hydroxychloroquine. It was not just meant for hydroxychloroquine. Multiple risk factors were studied, and one of the outcome was on prophylactic hydroxychloroquine. And this is the summary which he has prepared. He has identified that this is a observational study, and it's a retrospective case control study. The case control design is a very important design, but very simple design may not yield much of a meaningful outcome. Then why do we do case control study? That's because it's easy to do, and that usually is a first step in any hypothesis generating level. And interpretation of the case control study should be very careful, because you can go wrong in its interpretation unless you are very careful in interpreting it. And this was studied in healthcare workers who were given hydroxychloroquine, and he has identified that inclusion and exclusion were not given proper detail. That's correct. And cases and controls were defined in the study, and the sample size was estimated to be 484 based on certain assumptions. And data collection was based on telephonic interview most often, or questionnaire. So this was not a face-to-face interview. It was mostly questionnaire-based study, and sometimes telephonic interview, and a lot of data was missing also. And the analysis was basically on key risk factors for SARS-CoV-2 infection by comparing the distribution of the risks among cases and controls. That is the basic design of the case control study. You want to see the distribution of the risk in cases, that is, those who developed COVID-19, and study the distribution of the risk in those who did not develop COVID-19. So those were the controls. And he has given the description of the results in this PPT. There are 624 cases and 549 controls. And out of that, only 378 completed the interview. And he has identified that not all were recruited, or the samples were not complete. Many of them were dropped out because the number which was available for the final analysis was much less, 378 and 373. And the reason for refusal was consent refusal, wrong contact, neglected calls. Now, I'm highlighting all this because we need to go to these intricate details to analyze articles. Simply saying that they analyzed 624 cases is not sufficient. What happened to these 624? How many dropped out? And what was the reason for dropout? Was it mentioned in the study or not? That is not to criticize the study. We are just looking into the aspects why it happened like that. So while interpreting, we know how much of importance is to be given for these kind of developments. And mean age has been mentioned there. And vulnerability of healthcare workers were assessed, and it was adjusted in the statistical analysis. And it was found that endotracheal intubation had higher odds of COVID-19 infection. And this was the important result. Not using PPE had high risk of infection. Use of mask, cap, gown, gloves had reduced odds of developing COVID-19 infection. Not surprising. Now, there was a protective effect of hydroxychloroquine while taken for more than 4 maintenance doses, although they did have a lot of side effects, and the resident has clearly identified the side effects and the percentage of that. The percentages are significant: nausea, vomiting up to about 8%. And he has put this table, and it would have been nice if he had converted this table into his own table instead of cutting and pasting it. Because once you cut and paste it, first of all, it's not very clear. Second, you lose the freedom to modify these tables. And modifying the table is very important because you can highlight what you want to express, what you want to explain. In this slide, you will see that hydroxychloroquine had higher, the not using hydroxychloroquine had a odds ratio of 1.28 for cases, that is those who developed COVID-19. But interestingly, those who took more than 6 doses had a substantially less odds ratio compared to those who did not take it or those who took for 2 to 3 doses. And in these groups where they took for only 2 to 3 doses, there was increased odds ratio. That's really interesting and surprising that those who had only 2 or 3 doses had a higher odds in cases, and other drugs used also in combination were assessed. And he has put up this table again where adjusted odds ratio was mentioned. In the previous table, it was only the odds ratio. In case control study, it's very easy to be carried away by the odds ratio because there are many confounders. So to adjust for this confounders, for example, patient subjects who took hydroxychloroquine might have used good PP also. So to adjust for this confounding factor, there is a process of adjusting. So adjusted odds ratio has been mentioned in this table, and it shows that uh, those who did not use PP had a very high odds ratio of contracting COVID-19 infection. And hydroxychloroquine, especially when you take for more than 6 doses, had a substantially lower adjusted odds ratio. So that is how the paper is discussed and analyzed. And hello. Yes, I'll proceed. And this graph has been has gained a lot of importance in the last few days. That the proportion of patients who develop COVID-19 infection compared to those who did not take hydroxychloroquine, those who took for 2 to 3 doses, and those who took for more than 6 weeks. In those who took for only for 2 or 3 doses, there was an increased proportion, and then subsequently there's lower proportion when they continued for more than 6 doses. And this was uh, hypothesized to be a very important concept that after 4 doses there is good protection, although there is a lot of interpretation in that. So the summary of the paper was that there is a protective effect after 4 weeks of chloroquine, and so it reinforced our belief that we should be abiding by the National Task Force guideline that hydroxychloroquine should be used, and that it was quite safe, and that uh, there was a registry-based study which came out a few days ago, which has been retracted now, which said that hydroxychloroquine prophylaxis was having no benefit, and this is the comparison and the contrasting of studies which is done as part of discussion. And this is a very important slide which was prepared by our postgraduate student. Now, till now, what he has mentioned was basically from the study itself. Now, here he has given his opinion. Now, this is the most important point. He has identified that this is not a clinical trial. I didn't prompt anything to him. I just told him to analyze the paper, and he came out with his own conclusion. And that's what I said. You'll be surprised by the ability of the young minds to dissect the study and come out with the very interesting findings. Without any prompt, he said that this is not a clinical trial, so it has got very limited validity. It is an observational study, so it is just odds ratio, but not proportion, not even the overall effect size. So he has clearly identified that this has a very big negative aspect of the study. And he mentioned that inclusion exclusions were not fully explained. I agree. The authors could have given a little more clear-cut details regarding inclusion exclusion. And he also identified that sample size was not achieved. And first part of the dose response curve showed apparent increase in getting infected, which he identified as a very unusual thing, and that was discussed in, in the paper, but it is very unusual. And he very clearly mentioned that this was a flawed design. It is flawed design because for the purpose of the study question, this design is not very appropriate. If the study question is whether hydroxychloroquine is going to protect, the appropriate study design should have been randomized control study, or at least follow-up study, that is cohort study. The case control study design is not a very appropriate study for this purpose because there are many confounding factors. Disparity in data collection was identified by him. And another very interesting point was omission of test positive asymptomatic patients. The study focused only on symptomatic healthcare workers, but left out all those who were asymptomatic because probably because that was the testing criteria. But then by leaving out asymptomatic patients, we have got a big group of subjects who are missed out. Theoretically, it could be argued that chloroquine produced because of its anti-inflammatory property many asymptomatic positive patients, and by allowing these patients to be mixing with in the public, we may encourage the spread of the infection. This is a far-fetched but theoretical possibility. So that's why we argued in these journal clubs various aspects. Leaving out asymptomatic patient is a very big drawback of this study. And from facility to facility, there was a lot of difference. So these were his observations, very, very pertinent and important observations. And I've added my interpretation. These are my interpretations. This is a study which comes out with the odds ratio. It doesn't tell the protection. Odds ratio just tells you that this is what the occurrence was. It is not even a proportion, as was written in the graph there. It is just an odds ratio. And the other important complicating issue is that we are looking at the association, which is not causation. We are going by the association and converting into causation, saying hydroxychloroquine causes less COVID-19, which is overinterpretation of the study data. It is just an association, but not a causation. There are a lot of confounders. Those who were using good PPE could have been those who have got benefit, and they were also taking hydroxychloroquine. That's one possibility. And there are other confounding factors, which I'll come to later on. And there's questionable method for adjusted odds ratio. If you look into the chloroquine subcategory, those who never took, or those who took for 2 doses, and those who took for 4 doses and more than 6 doses, they were adjusted for each other in calculating the adjusted odds ratio. They're not mutually exclusive. You can't have a patient who is taking both more than 4 weeks and more than 1 month or 1 week, because these are mutually exclusive. And how can they be adjusted together? When two factors are together, then we adjust for them. So there is a serious methodological flaw in combining them in an adjusted odds ratio calculation. As I already mentioned, the better design would have been a cohort study, and case control is for a rare event. Occurrence of COVID-19 is not a rare event, so the appropriate design would have been a cohort study. An interesting aspect in the table, one of the tables was that more than duration of 1 year of working in the same area had higher odds ratio. That was not explained in the study discussions. Maybe that those who have been working in the same area for more than 1 year, they have some complacency and they do not take proper prevention. And if it has come as a significant odds ratio of more than 3, which was mentioned in the table, why was it not adjusted in the calculation of the adjusted odds ratio? And another important interpretational flaw is that 80% protection is mentioned in the discussion. It can't be 80% protection because it's just a number of comes from the odds ratio. 80% person can come only from the cohort follow-up study. From the case control study, we can't get that number because we get only the odds of a risk factor compared to odds of not having a risk factor. And combination of medicines, hydroxychloroquine, vitamin, and non-allopathic medicines, everything has been adjusted in the next table. I want you to focus on the green aspect, that is the last table. There, hydroxychloroquine only had an odds ratio of 0.85. Hydroxychloroquine, azithromycin, and vitamins had an increased odds ratio. Now, does it mean that addition of azithromycin and vitamin increase odds ratio? That can't be the case, because when you go to the next number, hydroxychloroquine and vitamin had an extremely low odds ratio of 0.21. So does it mean that hydroxychloroquine and vitamin combination is extremely useful? If that's the case, go to the line above that. Hydroxychloroquine with the addition of azithromycin, how does it become 1.6, which is higher risk? Azithromycin may have QTc prolongation, but it cannot alter the occurrence of COVID-19. So there are a lot of interpretation issues based on the tables itself. And hydroxychloroquine plus non-allopathic system of medicine had significant benefit. So is it because of hydroxychloroquine or non-allopathic medicine? So more questions are raised than answers from these case control studies. So it is just a preliminary hypothesis generating level, but it is still far, we are much far away from interpreting that hydroxychloroquine should be given routinely for patients with COVID-19. Now I'll move on to another topic which has already been given to you. That is role of remdesivir and most of you have analyzed this paper already. And I've gone through the PPT which has been uploaded by many of you, where you have added your inputs saying that the interpretation was not quite appropriate, and that the outcomes were not very meaningful. All that has been mentioned. Just 1 minute, I'm having difficulty in picking up the appropriate slide. My analysis of this paper is that the outcome is based on ordinal scale. There are 7 or 8 points in the ordinal scale, like getting admitted to the ward, getting admitted to the ICU on a low flow oxygen, high flow oxygen. Many of them are quite subjective. But the most important outcome was that mortality was not significant. It was only improvement in terms of some ordinal scales. Suppose someone was receiving low flow oxygen, and if he comes to a stage where he is shifted out of the ward, that becomes improvement, not recovery totally. So the recovery is defined as someone who is coming out of oxygen state also. So the outcomes are not very well clearly defined. And another important problem was that other medications were allowed as per local policy, so there is no homogeneity in this treatment arm, and it does not apply to all COVID-19 patients. Inclusions were those only who were admitted, hospitalized. So we can't think about giving remdesivir for those who are not admitted. Not everyone may get the benefit of remdesivir. And study was terminated prematurely by the data monitoring committee. There are a lot of controversies. I won't go to the details. But the subgroup analysis mentioned showed that the benefit was only in those who were receiving oxygen. How to do the subgroup analysis? This was the table there. So whenever we have this kind of tables, the faculty member can explain this to the residents. Otherwise, it becomes very difficult to teach statistical concepts unless we have examples. Each journal club can pick up one such concept and explain that. For example, in this table, in this figure, we know that based on the baselines, there are various outcomes seen here. In the those who are not receiving oxygen, the benefit was not really statistically significant. It crosses the number 1, which means there could be the improvement is not statistically significant. There was definite improvement in only those who were receiving oxygen, and those who were receiving high flow oxygen or were on ventilator, there was increased mortality. So the subgroup analysis concept can be very well explained by explaining these diagrams to the residents. So with these explanations, we can make journal articles very meaningful, and the residents can derive maximum out of that, and then they can, in the future when they have papers, instead of being guideline readers, instead of being blind follow-up, they can decide what is good and what is bad. It's like giving fish, or you want to teach fishing. They have to learn the art of fishing, and it is very easy for us to give fish to them, but we should desist from that. Our purpose should be to teach fishing to them, teach how to be self-reliant, and analyze the article on